So we're all credentialed, we've got our roster done, we've got a contract signed, we're gonna start providing services and submitting claims. So this next section is really about the very basic beginning of setting yourself up to bill. So we're gonna talk about what do you need to include on a claim to make sure it adjudicates correctly, how long do you have to file claims, which is really important, and sort of what are some of the options you have as an agency or organization to submit claims. We've already talked about the comprehensive billing guide. A lot of what Angela and I are presenting this afternoon is in the billing guide. You know, go back, read it at your leisure. It's super exciting stuff. But you know, if questions come up or you want to think through something and go back and find it in the billing manual, please feel free to do that. And just so you know, when you scroll down in the table of contents, it doesn't appear that they're hyperlinks unless you really look. But the table of contents, all the little lines are hyperlinked, so you don't have to scroll through, I don't know how many pages it is now. Just go to whatever, you know, whatever section you want to refer to, and it'll take you right there. So just don't spend a lot of time scrolling unnecessarily. All right, and again, just a reminder, what we're talking about here today is only for Medicaid. We're not talking about commercial billing, and we're not talking about the dually eligible MMAI population. Okay. Basics. What do you need to put on a claim? You definitely need to have the name and TIN number of the professional or facility that provided the service with the matching NPI number that you have in impact, right? So this is where it all starts to tie together. What you've got in impact as your NPI for your facility with that TIN has to match what you put on the claim, or the MCO is going to say, wait a minute, you're not credentialed to provide this service. So it's really important that those match up. Obviously, you want to identify the patient with their RIN or their Medicaid ID number, their address and correct date of birth, the date and place of service, any prior authorizations, if it's a service that required what we call PAs. Make sure that you transcribe that correctly onto the claim. Angela's going to talk about prior authorizations in a bit. And by the way, I am not the only one presenting, so if you're sick of hearing from me, Angela will be up next. So there is relief in sight. And it's really important that you're coding the claim correctly. So you have to have the valid diagnosis code on there, the procedure, if there was a procedure done, the modifier, and any location codes. And we'll talk a little bit about that when we dive into some of the behavioral health service billing. The other thing to remember is that Medicaid is always the payer of last resort. So you really need to make sure if there's any kind of third-party coverage, whether it's a workers' compensation thing or maybe they have some sort of commercial insurance or something. You got to make sure those are billed first because Medicaid is always going to be that payer of last resort. And this is important now, especially for if you use a third-party biller, you have to have the provider sign in black ink on the claim that it is true, correct, the service was provided. If you use a billing agency, you cannot use a stamp. If you use a billing agency, Jesse, and others that use billing, third-party billers, you just have to have an authorization connection so that that third-party biller has the authorization to sign on behalf of the provider, and they just have to initial it, but you just have to have that documented somewhere. Okay, so just in terms of coding guidelines, we went through the update to ICD-10 not that long ago. It's really important that you're keeping up to date on your coding. If you use medical billers, make sure that they are getting that continuing education. You always want to be using the correct code set for that date of service. So, just make sure that when codes get updated, that you update your billing procedures and policies. Because if you provide a service on day X and they've updated the HCPCS codes, and you use an old HCPCS code, it's going to get denied for inappropriate coding. Also make sure that you're using appropriate codes for age or sex, so you're not going to, again, this is more medical billing, I guess, you're not going to code a prostate exam on a female patient, and that's going to obviously get rejected. And if it is an ICD-10 code, that, it's so specific now in ICD-10, you got to make sure you have all those 5th, 6th, 7th digits included, or it will reject. Modifiers, and we are going to talk about modifiers. Obviously, we add modifiers to clarify a service that was provided, either in terms of the provider that, or the professional that provided the service. There's a lot of different reasons you add modifiers to a claim, and we will talk a little bit about those. But it's really important that you're using those correct modifiers. MCOs will follow national coding guidelines, which we've given you the National Correct Coding Initiative, NCCI coding guidelines, and there's a link in the billing guide to the NCCI coding guidelines. There are certain, because HFS likes to make things, exciting and interesting on a constant basis. There are some modifiers and some coding guidelines that HFS does not follow from NCCI. They're sort of shifting in that direction. So always follow, generally the practitioner fee schedules and the provider fee schedules that you find on the Medicaid website, on the HFS website, those are kept pretty up to date. Just make sure that you are using the correct modifiers that they're asking you to use in case they differ in some way. But generally they're following the NCCI guidelines as well. 2 types of modifiers, one that are modifying your CPT codes and others that are modifying a HCPCS code. So just so you know, there's 2 different types of modifiers. The other thing to know is that all MCOs will use some sort of software. So when claims are submitted, they have a software program, a third-party software program, that basically runs the claims through to make sure that the coding is correct, so that it'll catch like that prostate exam on a female patient, and it's going to spit it out. If it's an adult service delivered to someone under 18, it's going to kick it out. They're looking for upcoding. There's been fraud and abuse in the past from providers putting down a code that was probably better reimbursement but doesn't fit the diagnosis. So they're just constantly looking to make sure that the coding is accurate and that the claim is going to adjudicate at the right reimbursement rate. And again, if you don't follow those coding guidelines, you're going to see a rejection of your claim. So those are the basics on what you need to include on a claim and making sure that your coding is accurate. There's 3 different ways you can file a claim. You can file paper claims like a CMS 1500. You can do electronic claim submission through a clearinghouse, or you can submit directly to the MCO through their portal. Now, some MCOs will accept claims this way, some don't. So, you have to check and make sure, depending on who you're contracted with. Some will not. And there's an appendix at the end that goes through the portal functionality, so you can see which MCOs will accept portal submissions. And this is one of those little icon ones. Deciding how you want to submit claims is obviously an individual organization decision, and it really will depend on a number of factors. If you're not doing a lot, you may want to, and you're a very small agency, you don't have a lot of automatic and technological processes in place, you may want to just stick with submitting paper claims. If you're doing a lot of volume of claims, definitely probably makes sense to move to electronic billing. I know the MCOs always prefer electronic billing. You get paid faster with electronic billing. And then making sure that you read your contract language, because there are certain contracts that will say you can only submit electronically. We're not going to accept paper claims. And I know the MCOs will, they really move you to either portal submission or what we call EDI submission, mainly because it's obviously moves through their process a lot faster, it's a lot less labor intensive, and it's good for providers because it means you're going to get paid more expeditiously. So if you are going to submit paper claims, it's perfectly legal unless your contract says otherwise. These are some of the do's and don'ts. I'm not going to read through them in any great detail. The really important thing is you have to use the original billing form. So you have to use, if you're going to use, I'm assuming if you guys are billing, you're using the CMS 1500, you have to use the original red form. You can't just buy one and photocopy it 500 times. You have to get the actual forms, and you have to type them or submit them, do a fillable PDF kind of format. Don't handwrite them. Let's see, don't go outside the fields, otherwise it could reject. And again, make sure that everything is signed, sealed, delivered. Don't use signature stamps. Don't put any staples on there or add any extraneous information. These all, even though they're a paper form, they're still going to be scanned into the MCO system, and so they just only want to see what they need to see, and it's got to be within those boxes, and it's got to be legible. So that's paper claims. If you do decide that maybe your agency is going to be doing a significant volume of claims, and you're going to really look at doing electronic submission, these are kind of the steps, just sort of the baby steps to walk through, kind of like that impact flow chart. So you have to select a clearinghouse. When you submit electronically, you don't send them to the MCO. They go through what's called a clearinghouse, who kind of checks and makes sure that all the I's are dotted and the T's are crossed. So you have to enter into a relationship with a clearinghouse to submit your claims to. Let them know who you're going to be, or who your contracts are with which MCOs. Work with that clearinghouse to understand and build what data is going to be exchanging back and forth to make sure you're going to be sending it in a way that they can accept and that you're going to get data back. And this is a really important, and Angela's going to talk about this a little bit later when we talk about corrected claims and denials. But what you do, the way this works is you submit the claim to the clearinghouse. It does an initial pass to make sure that all those data elements that the MCO requires are there. If it passes that first screen, then it gets submitted to the MCO for payment or for adjudication, and then hopefully payment. If it does not meet those screens, like maybe you forgot a date of birth or you forgot a diagnosis code, or there's various screens it'll go through, it's going to reject that claim and it's going to send it back to you. That claim never got to the MCO. But every day they're going to send you a report that says these are the claims that we rejected and these are the ones that went on to the MCO and are with the MCO now. And it's really important to check those daily reports, because if you have claims that they rejected, you need to correct them and resubmit them. You can't just because you send it to the clearinghouse doesn't mean it necessarily got to the MCO. So it's real, and that gets to Angela's point earlier, to monitor those payments. So every day, look at that report. Oh, I submitted 50 claims, and these 10 didn't pass the first screen. I got to go find out what did I do wrong on those and resubmit them, okay? And then they will go on to the MCO. There are certain claims, I don't know that for the audience, at least from my understanding of who's here today, that you cannot submit electronically. Things like wheelchairs and things where you have to show pricing information and invoices, and there's sort of extra documentation that you need. So these are some of the things that you can't submit. You have to submit with paper because there's accompanying documentation that you're going to have to send in. But it's, again, much more specialized services, custom DME stuff, prosthetics, and things like that. Oh, man. Do it this way. So these are the provider portals. So we've talked about EDI going through the electronic clearinghouse. Again, some of the plans will accept portal submission, and it's really as easy as they'll show you that it's a fillable PDF, and you just key in all the relevant information and hit send. These are the portal. You have to sign up to be part of the portal to get an ID, because it's obviously you're sharing HIPAA compliant data. So we want to make sure that you have the right credentials to have access to their portals. But again, at the end of the presentation, they'll see I think there's just 2, Blue Cross and County Care don't accept portal submission, am I right? Anyway, you'll see it at the end. I'm pretty sure it's County Care and Blue Cross won't accept, but what's that? Blue Cross, yeah, and I'm not sure County Care does. But anyway, it's all down there, so. Timely filing is really important. All plans by contract will give you 180 days from the date that the service was provided or the patient was discharged from a facility to submit a claim. So that's 6 months. It's really important that you get on filing those claims as soon as possible, because it's not just 180 days to submit your original claim. You have 180 days to submit corrected claims. So especially when you're new at this and maybe you're not, firing on all cylinders in terms of your claims, you want to make sure you get that claim in as soon as possible. So if it gets rejected for some reason, you've got that runway to correct it and resubmit it. Or if it maybe gets to the MCO and they reject it for some reason, it's a second screen that says, wait a minute, there's something funky about this claim. If you hit that 180 days, that's it. You can't file a corrected claim anymore. So don't ever hold claims if you think, oh wait, I've got to wait for X, Y, and Z. Always send the claim in, because if there's something missing or something, the MCO is going to let you know. And we just want to make sure providers have that runway to get the corrections done, the replacement claims in, whatever the issue might be, so that they don't run up that window. Finally, electronic fund transfer. This is something that the MCOs really would highly recommend that you sign up for. It's basically just like direct deposit into your bank account. They'll send you remittance advice, an explanation of payment that shows you what they paid, what was denied, et cetera, et cetera. But the money's going to go straight into your account. You don't have to worry about waiting for a check to be cut or a check getting lost in your mailroom. This is just a direct way to get paid. So that's really just like the very bare minimum, deciding how you're gonna bill, making sure you know what needs to be on those claims, and the timely filing, I think, is a really important one. Just make sure that you have systems and processes in place, that the clinical documentation from your service providers is getting to your revenue cycle and your billing department so they can get those claims out the door. Yeah.
Because I know for private insurance, you have to get on their panels to be able to be considered in-network. Mm-hmm. So for all of the Medicaid options there are, do you have to then contact each one of those and get on their panel? Or
so
because you're an impact,
no, it's a great question. So that is the universal roster.
Okay.
So that's why that's a really great analogy. So if you're familiar with commercial insurance, the universal roster is basically the MCO's panel of in-network providers. So if you've submitted the roster for your agency and the providers that are serving in your agency, that's basically their panel.
Thank you.
All right. Any other questions? It's pretty basic stuff. Yeah.
You mentioned that you receive approvals and denials through the remittance.
Yes.
So what's the turnaround?
So Angela's going to talk a little bit about that, because we're going to get to, so what really only happens on the front end of the process is those rejections. It just means there's something missing on that claim. That happens, like very quickly. I don't know, what is it, like a 20, yes. It's almost instantaneous. I mean, once you submit the claim, it's going to spit it out or accept it. We're going to talk a little bit about rejections and denials from the MCO a little bit later, and Angela's going to talk to you about those explanation of payments and those kind of timeframes. So hold that question; it's an important one. Anybody else? All right. Oh, yeah.
Well, here. So I imagine that the claims are connected to how the provider is documenting, if that's relevant to the diagnostic
Absolutely.
codes or all that kind of thing. Can you point in the direction of a good resource or training for those providers to really understand, if they're moving from a non-Medicaid billing system to a Medicaid billing system, how they're supposed to document, how they're supposed
Absolutely.
to diagnose? Yeah.
I think that's a really important question, and that was a lot of what we heard when we were preparing for today from those folks that have made this transition. And it was one of those surprising things was how you think of this as a billing exercise, but it really goes right back to when the patient first shows up at your door, and Angela's going to talk a little bit about that related to eligibility. So how you register them at the front end, and then what is your clinical process? What's your workflow look like? How is that being documented? And how does that flow back into the billing and submission of a claim? We're going to have a provider a little later today that has spent, one of their biggest lessons learned was training. So I think she'll be a great resource to talk through some of that. All right, Angela, I'm going to turn it over to you.